we clearly are seeing at this ASH meeting, a tremendous amount of interest. One of the plenary abstracts regarding, the addition of a FLT3 inhibitor to patients who are FLT3 mutated, along with 7 and 3. There's other abstracts looking at adding sorafenib. There's a lot of interest of adding other components, specifically on the induction side. Did you guys? What are the thoughts around the evolution of that? Are we at a point now where that should be viewed as a new standard?
In a FLT3 ITD patients, for example, where the plenary session, PKC-402, adding to chemotherapy, improve response rate and overall survival is really great. In our hospital, when we went retrospectively to all historical data, in patients with FLT3 ITD mutation, giving FLT3 inhibitors has improved overall survival of these patients. No, these are not randomized trials. It's a trend. You phase 2 studies, but you compare them in a similar patient population, they are improving survival. The Germans have reported this trial where they added FLT3 inhibitor. Well, sorafenib is not, it's FLT3 inhibitor among other kinase inhibitors, but clearly showing improvement in outcome across the board, regardless of the FLT3 status. The question is today, in 2015, should we implement adding kinase inhibitors across the board for everybody? I don't know the real answer for that. However, I can tell you at my institution, the tendency is yes to add sorafenib across the board.
Regardless of the mutational status?
Correct.
So I think I want to start to say this is very exciting to have a plenary session with a study with a drug that shows survival advantage in AML. We've been long time waiting for a new treatment that improves the outcome. And I think the impact of this treatment in this population that carry the mutation from this study is going to be important. And I think it will change the standard of care. So I think in that defined population that the study had done the FLT3 inhibitor, I think that will change the standard. And I agree with Eli that I think the FLT3 patients, clinically we see benefit for them. The studies sometimes were not selective for FLT3 positive patients. But there are different things that we could, there are other things we are looking at in a way that to improve the outcome. So basically, some of the simple things that had been subject of research for a long time, adding third agent chemotherapy. There had been studies done in Europe, for example, looking at cladribine addition to an anthracycline plus cytarabine. And in their studies, there was survival advantage. This had not been adopted or used much on our side. There is data about gemtuzumab that was available and was the drug approved at one point for relapse refractory AML, that maybe in younger patients adding it to the backbone of intensive chemotherapy could be a thing. Now we are talking again about the FLT3s becoming a standard of care. So there's exciting, I think, opportunities here to improve the outcome. I'm really very excited about a drug that shows survival advantage in younger AML patients. We've not had that for a while.
I want to highlight something very important. Just to finish in the cladribine, we present at the ASH meeting adding clofarabine to doxorubicin and RSC. There was a study published in JCO from Poland where they add cladribine to 3+7. They showed improvement in overall survival. So in young patients who can tolerate chemotherapy, adding clofarabine to RSC has shown a better event-free survival in younger patients who can tolerate chemotherapy compared to doublet. Now, one thing we always think when we treat a patient, elderly or young patient, what is your early mortality rate? Correct? At 4 weeks and 8 weeks. And the significant progress made, at least what we may ignore it or underestimate, is supportive care. Dr. Este published that in patients who are 50 and older, by doing optimal supportive care, like induction in protective environment, laminar flow, antifungal therapy, antibiotic, we were able to reduce mortality by 10% at induction, which is great. We haven't done yet chemotherapy or the prognostic feature and others, but having a good supportive care for this patient is crucial. In MDS patients, they die from infection more than acute myeloid leukemia transformation. So it's crucial to have great supportive care and great team in order to minimize this and then improve the outcome.
I mean, I think it is so true. I think we can really focus the long term in terms of who's going to be the donor for the transplant,
right?
In the high risk patient, and in the second week, they're in the ICU with a life-threatening infection. That could be a key part.
To your point, Eli, sorry, we actually have a poster at this ASH trying to look at the short-term mortality with induction chemotherapies, you clearly see increased mortality in patients above age of 70. Your group had published about predictors like serum creatinine and all that stuff, but we were thinking to create data to see if we can move the intensive chemotherapy down the road as an outpatient regimen to try to identify patients that will be at lower risk of mortality that can be moved out. But in patients above 70, we still see around 10 to 15% mortality, and most of those are sometimes actually infection.